Good evening, all the aspirants. So today's topic is it's Station 3 Neurology, and the speaker that we have here is Dr. Anand Joshi, sir. He is a consultant intensivist and physician at Government Hospital, Hyderabad. Yes, sir. So you can take over.
Thank you, Fatma. Good evening, all, and welcome to another exciting session where we are going to go through what you're going to see in Station 3 of your PACES examination. Now, because this would be a Station 3 is not a unilateral lecture, it's all you have to present it. For the initial, I will take you through a case with it, and then a bit of an interaction for the initial thing would be helpful, instead of just being a a passive audience. I'm going to then take you through what would be the correct way to answer and how usually the case goes through. You will be given a short case summary or case vignette, as we call it, and that's how the things will move. You will be told that this is basically a neuro station or a gastro station kind of thing. So there is nothing major confusion in this. So let's start. We've got 65-year-old male who presents to you with a 2-year history of slowness of movement, and he complains my hands are shaky, especially when he's just sitting idle. He complains vague that he's finding it a bit difficult in doing his daily activity. He says that it's pretty getting tough and tough. He feels bit overall stiffness. He's not able to do his activity as smoothly as he used to do. There is no history, denies any history of any stroke, or he is not on any drugs or any family history of any movement disorder. So what are the additional questions you would like to ask?
We can inquire about his gait.
Gait, good, very good.
Any motor weakness in upper or lower limb?
Perfect. Then
we can also ask him about the nature of the, if there was a in onset was symmetrical or not. And then, sir, we can also
onset, yes,
symmetrical or not. And sir, if there any history of blackout palpitations.
Why would you ask for, it is right, but can you elaborate why would you ask for blackout and palpitation?
So because we need to rule out if this is just Parkinsonism or Parkinson plus.
Very good, very good. I like it. Very good. Next.
We can inquire about his tendency to fall, if it is there or not.
Very good. Fall. Okay. Yes. Then. Yeah. So you guys have covered most of things. Anything else?
So what makes it worse or what makes it better?
Sorry?
So what makes it worse and what makes it better?
Correct. So just a quick thing, just go back to your MBBS methods. Most of them applies here also. So when you are suspecting something, you ask positive symptoms and then you ask the negative history pertaining to that, as you rightly did just now. Gait, what is the gradual onset, whether he's got a fall or not, whether it's a symmetrical, asymmetrical, difficulty in difficulty in walking, whether he's able to wear his chappals or not. You can ask his family members how's his movements happening. Then ask about the cognitive functions or the higher mental functions of it, whether he's forgetting anything, whether you feel that he's getting demented, whether he's becoming disoriented intermittently. Then you can ask about, as you rightly said, motor weakness, upper limb weakness, lower limb weakness. And last but not the least, you should ask about whether he is able to open his bowels properly and he is able to pass his urine. So this would give you a decent idea that you're dealing with a neurological things. You will also be able to delineate whether you are dealing with some brain issues or whether you are in presynaptic, postsynaptic, that is upper motor neuron kind of issues or a lower motor neuron kind of issues, and whether he had any such symptoms, recurring symptoms or similar kind of symptoms before. Correct? So now it's once you have gone it, I will go with a slightly in detail about this question. So for this presenting complaint, especially now you know what you are looking at. You are looking at somewhere a diagnosis around Parkinson's or Parkinson's plus or motor neuron or Parkinson related or similar mimicking disease diagnosis. So when you ask about the things, whether you are talking about the shakiness, you are talking about the tremors. So when you are talking about tremors, the first thing you have to confirm whether what he's talking about is a resting tremor or not. So here in this gentleman, he had on the right side, it was a classic pill rolling, and it worsens at rest. So that's why it's called as resting tremor. The second thing you would be focusing, and as you rightly pointed out, was gait. So whether the gait has slowed, whether there is a difficulty in initiating the movement. So for that matter, whether it's just sitting and trying to grab a cup or grab a stick or trying to grab something. So that would give us an idea whether this gentleman has got any bradykinesia or not. Then he can say about he may complain, he or she may complain of the difficulty in doing the work. So you need to elaborate. What do you mean by, can you elaborate, or what do you mean by difficulty in doing the work? That means whether the limbs are stiff, whether he is able to grasp something and he's difficult to leave. So all those things would come under the, you're looking at a rigidity. And then yes, whether there was any history of fall, as one of you has rightly said. This fall may not be the first symptoms. It may be a bit later, but then it will not be a recurrent or obvious. It will be an occasional, as subtle as occasional imbalance. Hence, it's not directly just a fall. So if we say that, have you fallen? He may say no. But if you ask that whether you had an imbalance, then he would say yes. So that is a catch here. So if you stick to a concrete fall, he might not have fallen because he would have been using stick, or he is a little bit early in that, and then he may say, yes, I do get imbalance, but I have never had a fall. What are the past history you would like to know? Past or the social history?
Is there any medication taken for this symptom?
Very good. Medications you haven't taken for any symptoms. Then, so when you ask for a medication, right? And this is a real world experience I had. I had one of a patient who came with the worsening of the Parkinson's, was already on medication. And despite me asking 101 times, they said, no, we are not on any special medication, special medication, special medication. They kept on saying, we use only Parkinson's and some BP tablets. Okay. Then after 5 minutes of asking, when I specifically asked, have you taken any kind of medication? I said, yeah, recently I had went to a party and then I had ate a lot of spicy things. So I got some acidity. So I went to a local doctor and he gave me acidity tablet. Guess what was that?
Levosulfuride with PPI.
Correct. Correct. So that patient received, no, the patient said that patient girl was little bit a semi-literate. So they said we had a Pantodac. So when I asked them to show me the tablet, it was a Pantodac with Lesuride. So be very, very, very careful when you take this medical history and especially the drug history, and ask them to show, because the prescription was of the Pantodac. However, the chemist, overwise chemist, as happens in India, he gave him pantoprazole plus Lesuride, and this is where she ended up with. So be very careful. So first was the medication of the past history, then
We can inquire about any comorbidities.
correct. So
Related
never forget to do the routine past history. Hypertension, diabetes, hypothyroid, vitamin deficiency, cancer, all those things you should ask. Smoking, alcohol, you should always keep on asking, and in detail, because smoking and alcohol would, over the period of time, can cause shrinkage of the brain and the dementia and Alzheimer's and all sorts of things. So that may complicate your existing thing, or you may end up looking at a Parkinson plus. That's going on. Social history would help you to gain whether recently he has gone down on his friendship, whether there is a development of depression or confusion. So all those things, whether he has stopped going outside. You may ask, why I don't feel like going outside. Why you don't go outside? Because I feel like I will fall. It would be as subtle as that, right? So this would be these questions, which are more of a social kind of thing, would actually impress your examiner that okay, this guy is thinking in a much more broader way. One of the key thing the examiner is looking at during this quick brief period is how broadly you start and how quickly you narrow it down. So if in one breath you give them the past history, no significant past history of medications that can induce any kind of abnormal movement, no past history of any antipsychotics or antiemetics been taken. The patient continues to stay in at home and denies any reason for him not going out, or anything you can ask on those. And then you can say no past history of hypertension, diabetes, family history of Parkinson's, thyroid, or any vitamin deficiency. If in one breath you say it all, it is not necessary whether you have picked that history correctly or not. The fact that you have asked itself give you a tick mark, for the reason they also understand that many a times in that short period of time you may not be able to actually go deep down and elicit. So having a tick box of the past history and social history is very helpful. So no antipsychotic or antiemetic drugs were used by this patient. There was no significant cerebrovascular risk factor, hypertension, diabetes, smoking, alcohol, non-smoker, moderate alcohol was there. Now, if the vignette will end up, you examine the neurological conditions, then you have to, sometimes it usually it may not happen because it's a very neurological examination is pretty large. They may ask specific things about it. So they may ask about the general neurological examination. They may ask. They may not ask for the systemic ones. If there is some hemiplegia, paraplegia, or any brainstem stroke or any cranial nerve involvement, then they would ask a specific cranial nerve involvement, or just examine a cranial nerve or any kind of thing. Having said that, it will be worthwhile to mention as we go in one breath. So the higher mental, just make a checklist in your brain, higher mental functions for a specific neuro exam, higher mental functions, cranial nerves, motor examination, sensory examination, reflexes, cerebellar, and gait. So these are like 6-7 points. So make a checklist and just try to keep the things in a perspective. If it's asking general examination pertaining to the case, then you are looking at general features, especially the Parkinson's features. So what would that be? Mask-like face. So where this patient had a mask-like face with a decreased blink rate, low volume monotonous speech. I'm just going to go through the positive points for your Parkinson's findings, okay? And that would be standing in, maybe sometime you may not have touched the patient, but these are the things which you would observe. Pin rolling, resting tremors. Now, sometimes the examination, those patients are being actually told to hold their hand together. So if they clutch their hand, then you may not see the pin rolling resting tremor, in which case you may have to ask this patient actually to rest his palm on his legs and just leave it. You may see slowly those tremors coming back, right? Then when you examine, you will look for the tone of the patient arms, in which you have to look at the lead pipe rigidity at elbow and cogwheel rigidity at wrist. So that is very important, because that's where you get the positive findings. So at elbow, you look for lead pipe, and at wrist, you look at the cogwheel rigidity. Then you ask the patient to walk or get up, or do some movement, then you may note as a bradykinesia. There will be difficulty to initiate the movement. That is, you may ask, can you get up from the chair? So they may take a bit of a time to get up from the chair. And when you ask them to walk, they may have a stooped posture. Arm swings would be decreased. So even if the stooped posture is not obvious, uh, you will strikingly note that the arm swings have gone down. And as the person starts walking slowly, his walk becomes short shuffling, or what we call it as a festinente. You may ask for a set. Now, these patients may not be able to do a tandem walking. So maybe dysdiadochokinesia and finger nose testing might be somewhere you to rule out any cerebellar signs, and the pyramidal signs, which would be normal. It is very important that these people have this normal documented or as a negative history. There should not be any gaze palsy to rule out any focal deficits. Sensory examination, just a quick general sensory examination, touch, he would be saying it as a normal. So actually in almost like 1.5 to 2 minutes, you should be able to quickly demonstrate that. You can ask about the bladder bowel, which would be interrupted by the examiner and say it's normal. When you talk to the patient, and if they are if they are allowed to talk, or whether you are given a chance to interact with him, try to quickly ask, how are you? Do you know where you are? What day or what time is it, and which place is this? If you have this brief thing, which year is it, then that will give you an idea about an higher mental function, and that will also give an examiner that okay, he has touched that point of the higher mental function. So in this patient, he had a slow progressive asymmetrical Parkinsonism. There were no red flags for Parkinson plus, and there was a normal cognition. So you can, once you have done it, it gives a very good impression to the examiner. Once you have done, so on summarizing, my patient is a 62-year-old who has come with a slowly progressive asymmetric, what looks like Parkinson's feature. I don't see any atypical Parkinson or Parkinson plus feature, and he's got a normal cognition at this moment. So that will actually, just at the end of the history, that will actually make you in a very comfortable position once you summarize the whole. So obviously the diagnosis is we are looking at a Parkinson's disease, right? At station, when this kind of patient is there, you might be asked, like a common instruction at this patient is, the patient is seated on a chair, and they may just ask, look at the patient and examine as appropriate. I mean, they don't get completely baffled or something. When they give you such kind of vague thing, examine as appropriate, just look at the general thing. So what are the different cases? And usually it is the Parkinson's case, because the things are very obvious in these kind of things. So expressionless and low monotonous speech from outset provides a clue. So if you go and you introduce yourself and ask him his name, glad to meet you, where you do you know where you are, which is this place, what is the date. By this time, you will just to give me a second. So the patient will have an expressionless face and low monotonous speech as he answers you, and that will give you a clue. And once you have picked up, you should be going through all the features from top to bottom. So I will just get you through what are the things you should be looking. Not necessarily you will be able to do everything, but if you are able to grasp most of things, that's good. Not necessarily you will have to go through each and every line, right? So these are certain explanations which I have formulated, and I've got from a few texts and readings, and I liked it and I have kept it, and that would help you to keep in mind the features, and so that you don't forget why these things happen. So the patient with Parkinson's disease have characteristics expressionless face. They call it as hypomimia, often described like a mask-like. This is a manifest. So mask-like face itself is a manifestation of the bradykinesia. Now, another thing is the blinking rate. The blinking rate is significantly low as compared to a normal person. There used to be what they call it as a glabular tap, that is Meyerson's sign, but it's not recommended in the examination, so don't do it, and it's quite unreliable sign also. It usually involves, for those who don't know, it involves tapping on patient forehead repeatedly, and after a normal subject stops blinking, but in Parkinson's, the patient continues to blink. Patient may have a bit of a drooling of the saliva, so that may be a part of the dysphagia or siluria. The patient has a very soft speech, which is called as hypophonia, again manifestation of bradycardia, and characteristic, the speech is low volume, monotonous, and tremulous. Blepharoconus is a tremors of the eyelid. So if you just ask him to gently close the eyelid, there will be a bit of a stuttering or a kind of tremors will be seen. This will not be there if the eyes are closed very tightly. So be careful when you ask them to close the eyes. Tell them to close it lightly and not tightly. Tremors are something. Remember, in these kind of cases, most of the questions or your marks will depend upon how well you describe or catch the clinical signs. And in Parkinson's, tremors are very hallmark. The classic tremor is present at rest, and they are asymmetrical. It is classically described like 4 to 6 hertz, but we don't see that. And it's initial symptom in 60% of the cases, although 20% may never have a tremor. So just because the doesn't have a tremor doesn't mean that he doesn't have a Parkinson's. They appear as a pin rolling motion or the simple oscillation of hand or arm. It is easier to spot a tremor if you ask a patient to raise their arm in the lap as we speak in a semi-prone position. The tremors are usually seen in the hand, but you may notice sometimes in foot or even in a jaw tremor, which is rare. I have never seen a jaw tremor, honestly, but it's mentioned. Now, tremors may be enhanced by mental activity, not the physical activity. So you can divert the patient's mind by asking to count backward for 20, and with the hands dangling on or the patient lap or the armrest, and then suddenly you will see the tremors coming back. Usually these are the unilateral in onset, begins in upper extremities, and initially may be intermittent. After several months or in few years, it may present on the opposite side, but it is often marked on one side and asymmetry is often maintained. This asymmetrical sign supports the diagnosis of Parkinson's disease as opposed to Parkinson's. They are increased by walking and emotional stress. It disappears during sleep. Now, remember, these tremors we are talking about are the tremors of the hands. Some people do present with a classic titubation, but they are not Parkinson's disease, and they are more associated with the essential tremors or any cerebrovascular accident. The next one which you would be expected to show is the rigidity, which is also another classical features. And its a proximal and distal rigidity are a bit different. The proximal at the elbow, you look at a lead pipe rigidity, and it has to be differentiated from the spasticity of the upper motor neuron lesion. So here the increased tone is more marked at the onset of movement and suddenly decreases, which is in the spasticity. It is called as clasp knife phenomena. Whereas in the lead pipe rigidity, it is best felt on the passive flexion and extension of arm at the elbow, and it can also be demonstrated at the knee. So it will be even all throughout. So all throughout the passive range, this will be there. Hence, that's it's called a lead pipe rigidity. As against that, the cogwheel thing you are seen at the wrist, and it's a combination of rigidity and a tremor. So at the wrist, when there are also tremors happening, you can actually try to hold the arm and take the wrist and gently move around, and then you can see the cogwheeling kind of rigidity happening. The third one, which is a classic, is the gait and posture. So the characteristic posture is a stooping forward with lower head and flexed knees and elbow. Now this is probably the classic one, and you may not see all the component in that. Now, because of the lead pipe rigidity in the upper limb and the lower limb, there will be both flexors, increased tone in both flexors and extensor. However, tone is slightly more in the flexor, resulting in a flexed position. The gait of Parkinson's is very characteristic. They will be stooped forward as if they are chasing the center of gravity. They will take a small shuffling step. Feet may scrap the ground. It is a narrow base, regardless of how advanced the disease is. Now, if the walking is not a narrow base and it widens, then think of the alternative diagnosis, especially multi-system atrophy with cerebellar degeneration. When you ask them to initiate or walk, they will be particularly difficult initially. And the classic one is the turning test, which we call. So you ask them to move. They may move in a reasonable fast manner. If they are old, then they will walk slowly. And then ask them to turn around. So usually in a 3-step turn, they should be able to facing you. But if it's Parkinson's or Parkinson's features are developing, then they will take more than 3, 4, 5 steps to take the half circle or move from facing away to facing towards. So this is how you would gauge the early Parkinson's if you find that the gait is not what you are expecting. The second thing you would see when you ask a patient to walk is the significantly reduced arm swing, and it is very, very sensitive sign and maybe the first sign of Parkinson's disease. So you can carefully watch both the arms while the patient walk across the room and look for asymmetry. The foot often scrapes the ground on the side of the reduced arm swing. Walking also accentuates the hand tremor, so look carefully for this. Right? Now, about the history of the fall. So, why does a fall occur? The patient have lost their postural reflexes and increased, and that result in an increased tendency to fall. There is also a term called as propulsion, forward movement, and a retropulsion. So for that, you demonstrate it by a pull test, which is performed by you stand behind the patient and pull the shoulders back. So instead of moving the arm forward and swaying back, patient with Parkinson's may step backward or even fall back into examiner's a hand without attempting to maintain the balance. So they are easily you will be able to push them and they would lose the balance. So after having recognized these classical features of bradykinesia, tremors, and demonstrating postural instability, you can the examiners would ask, would you like to know anything more? You can ask them about the blood pressure, heart rate fluctuations, whether he had mentioned particularly you would like to see the postural drop of the blood pressure, which signifies the autonomic dysfunction. He said, if the given the time permits, I would like to do a mini mental test score and also would assess the handwriting. Try to look for this seborrhea or seborrheic dermatitis, that is abnormal sweating, as a manifestation of the autonomic dysfunction, but you may not always find it. So the top three are the one where you need to close your examination or close the finding by asking about the vitals, blood pressures, especially the postural blood pressure, cognitive function, handwriting, to be specific. Any questions so far?
So what is Parkinsonism plus?
We are coming there. We are just now ended with the what you will be doing when the patient when the case vignette is given, and how would you approach that, right?
Sir, I have a question.
Yes.
Sir, so before performing the pull test, do we need to explain the patient what am I about to do?
Sorry, I didn't get that.
So before doing the pull test on the patient, do I need to explain the procedure to him?
Yes. So when you do that, you tell him that you stand here and I'm going to stand behind you, and I will be, you will be safe. You won't fall. I will catch you, but I'm just gently going to pull you back. Right. So he may, otherwise many a times what happens that it's very, 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 very important that you demonstrate that you are safe to the examiners, right? If you feel that this patient is obvious and you need not demonstrate the pull test, you would just describe that there is something called as pull test, but I would want of time and safety, I won't be doing it on this patient. Clearly you tell that. So in that way, two things have happened. One, you are told that there is something called as pull test, which you find it to be unsafe and you are not doing it. And that would also add to your point that, okay, you command safety over demonstration of the sign, which is very much liked by the Westerners. All right.
Thank you, sir.
Yeah. So coming to the Parkinson, the diagnostic criteria, because based on UK Parkinson Disease Society, would be a bradykinesia plus rigidity or resting tremors or postural instability. And the supportive features would be unilateral or the onset or a good levodopa response. This is just for your information. Now coming to the differential diagnosis. So when you say that my patient exhibits an evidence of Parkinson's feature, it might be because of the Parkinson's disease classic or other differential. So when you talk about the other differential, that's when you come across, you say that it's either an idiopathic Parkinson disease, which is the most common. It might be drug-induced Parkinson's features, that is the metoclopramide or prochlorperazine sodium valproate. So I would like, even though in my drug history I haven't got, but I would like to go and check and retake the drug history in details. There might be a tumor of the basal ganglia, which is a Lewy body dementia, which is also a part of a Parkinson's disease. Dementia pugilistica. Can anyone tell me what is it is?
This is a type of an encephalopathy state caused due to repeated trauma in the brain, commonly seen in sportsmen who are involved in heavy physical contact like boxing, rugby.
Give me a classic famous person who had this.
Boxer Muhammad Ali.
Correct. Muhammad Ali got into Parkinson's, but it was a chronic head injury. He took so much of pugilistic is a boxer, right? Then the other differential would be a normal pressure hydrocephalus. Past history of any encephalitis, and then getting into this kind of thing, think of post-encephalitis also. Anoxic brain injury, post-cardiac arrest is another differential. Wilson's disease in a young patients with care pressure ring or known case of Wilson's, you may have this. Toxins, carbon monoxide, manganese, and last but not the least, Parkinson plus syndromes. So Parkinson plus syndrome, it's not that Parkinson and Parkinson plus, these are only two differentials. There are other differentials also, particularly drugs, hydrocephalus, encephalitis, anoxic brain injury. Of course, you will have other features also, and other vignette will be different, other things will be different. But dementia pugilistica is something, carbon monoxide toxin would be another thing. Old age people, the home burned down and then been rescued, and then whether you are confused whether these are Parkinson's features or carbon monoxide poisoning, it can happen. And last but not the least is a Parkinson plus syndrome, where three major things you need to rule out. One is a multi-system atrophy, progressive supranuclear palsy, and corticobasal degeneration. So you might be asked, okay, you have done, this is the Parkinson's, most likely the Parkinson's disease. So for your information, what's the Parkinson disease? It's a neurodegenerative disease. These are the things which you need to, these are some of the words which should come when you are giving an answer in any form. This question may come in different form, in different way, but at some point of time, you may be asked to describe the Parkinson's disease. So if when you're describing, grab this thing. Three things you should say it. One, it's a neurodegenerative disease caused by disruption of a dopaminergic neurotransmitter. Simple. Then that's where you started. Histologically, there is a law. You may or may not say about this histology, but histologically, there is a loss of melanin containing dopamine neurons in the substantia nigra and cytoplasmic inclusion bodies called as Lewy body. There is a loss of dopaminergic neurons, most prominently in the ventrolateral substantia nigra. Approximately 60 to 80% of the dopaminergic neurons are lost before the motor signs of Parkinson's disease emerge. So Parkinsonism and Parkinson's disease. So Parkinsonism is a subset of Parkinson's disease. However, practically when we talk about the Parkinsonism, you are talking about a symmetrical, rapidly progressive disease with Parkinson's plus signs, which we'll be seeing downstairs. And classic Parkinson's disease would be asymmetrical. They will be slowly progressive, and they have a good response to the levodopa. Remember, till you have treated or given a trial of levodopa, it will be difficult for you to confirmly say that this is a Parkinson's or not, because many a time, and this is not for the examination point of view, many a times in the practical history, if the person is coming early in his disease, then many times you may end up giving a levodopa and look at the response to the levodopa. Hence, and it is not a wrong thing to do, because in differential criteria only response to the levodopa is one of the criteria of the Parkinson's disease feature. So it's not that you who is uncertain, it all over the world it is the same thing. So as we came just now, somebody asked what is the Parkinson's plus syndrome. They are again neurodegenerative conditions with Parkinsonian characteristics, but in additional features that distinguish them from idiopathic Parkinson's. So what are those? So the clinical clues that suggest Parkinson's plus include poor response to levodopa, marked asymmetry of signs early in the disease, early onset dementia, early onset postural instability, early falls. So these are all the rapid. See, in Parkinson's, these are the things which will be slowly staggered way things will be coming. But here, everything is rapidly happening. Maybe in 6 months, the patient is showing postural instability. He had a falls. He is hallucinating. He's got dementia. He's got autonomic dysfunctions. He may show pyramidal sign, and this can, which cannot be explained by his previous strokes or spinal cord pathology. He may demonstrate cerebellar signs. He may have this gaze palsy or nystagmus. Sorry. Gaze palsy or nystagmus. So these are the clues that would suggest Parkinson's plus syndrome. Am I clear?
Yes, sir.
Yeah. Somebody had doubt on the Parkinson's plus. Does this slide answer your question?
Yes, sir. So actually, I want to know what is the differentiate from this disease from other neurological diseases like involvement CVA वगैरह, where there will be early dementias and postural instability.
Correct. So that is, so as I said, if you go to the differential diagnosis on this, so it's not only Parkinson's disease and Parkinson's plus. It's not that patient coming with the tremors, rigidity and all those things will have only two differentiations, Parkinson's and Parkinson's plus. ऐसा नहीं है कि if it's not Parkinson's disease, then everything else is Parkinson's plus. No, Parkinson's plus itself has got a complete different entity. Other differential, if we go back, see, if we go back in other differentials, you have drugs, you have a tumor, you have a dementia, prognostica, you got normal pressure hydrocephalus, encephalitis, brain injury, Wilson disease, toxic, and Parkinson's plus syndrome. That's where always we get confused. Now, if these kind of
Okay, sir. Okay, sir.
this kind of patient comes even in our day-to-day life, we only think only two things. जो है, either it's a Parkinson disease. If it's not Parkinson disease, everything else is Parkinson plus. No, it's not like that. It's not like that. Parkinson's plus is one of the differential. Beside that also you can have drugs, tumors, hydrocephalus, encephalitis, all those things are there. And that is one of the reason why you may find people adding levodopa in say hydrocephalus patient or a post-encephalitis patient or anoxic brain injury. You may say the patient doesn't have differential of Parkinson's disease. Why we are giving levodopa? No. Sometimes this levodopa will be helpful in this kind of thing also. May not be Parkinson's disease, idiopathic Parkinson's disease per se, but it may be helpful in these kind of situations, right?
Yes, sir.
Right. So this slide tells you about the Parkinson plus syndrome in particular. It is not explaining to you anything about the drug induced or anoxia or Wilson's or post-cardiac arrest or poisoning. No. This slide is telling you how to differentiate between the Parkinson's and Parkinson plus syndrome. Remember, what is the first one? Poor response to levodopa. So they are so overlapping that sometimes you just have to give levodopa and see if they are not responding very well, then probably you're dealing with the Parkinson's plus syndrome. Okay. The second would be always after that important question which you asked. The second would be, how do you differentiate the tremors in Parkinsonism and essential tremors? So that's another thing. So essential tremor is usually symmetrical. So symmetrical, anything which is symmetrical is in tremor, your brain should start thinking anything other than Parkinson's. It worsens with the voluntary. If you ask them to hold a cup, then it will be they may break the cup. Usually accompanied by the voice and the head tremor, like a titubation. In Parkinson, tremor can affect jaw, tongue, chin, but not the head. Remember that. If somebody's got a titubation, it may not be Parkinson, because you don't get this thing in Parkinson. You may get Parkinson's in the jaw, you may get like in the tongue, you may get in the chin, but not the whole head. 50% has a postural component, leading one to incorrectly diagnose essential tremor. So remember, only if you ask the patient to sit and hand in the semi-prone position, and if it doesn't move, then probably you may say, oh, this is not a Parkinson's, because in semi-prone position it is not a resting state, it is not. Remember, 50% of them may not have that also. So be careful when you diagnose. The one of the way which again in examination I asked or I mentioned was to ask them to write. So in Parkinson's, the tremor abates and the script becomes smaller and smaller. That is a micrographia. In essential tremor, the tremor exaggerate and the script become larger and irregular. So that becomes a differentiating point. All right. Then the next question will be, how will you investigate this patient? So don't try to jump on too many things, because there are not many things in the Parkinsonism or neurodegenerative for the diagnosis. So you have to mention that the diagnosis of the Parkinsonism essentially is a clinical. However, I would like to rule out any other structural lesion and other micro and micronutrient deficiency. So for that, I would like to get this patient MRI done to rule out or exclude any structural lesions, and the basic lab test with CBC, ESR, urea, creatinine, electrolytes, and including TSH, B12, and D3. Now, any specific test, if you are asked, then only mention about the DAT spec, that is a dopamine transport scan, which is not very widely available, or you can mention I haven't seen so far. However, even this will tell you that there is a problem with the dopaminergic neurons, but it will not say whether it's an idiopathic Parkinson disease, whether it's Parkinson progressive supranuclear palsy or multisystemic atrophy. So again, it is not going to be differentiating you from Parkinson disease versus Parkinson plus. Now, when you ask for the management, always say that I would like to take into a detailed history, drug history, past history. And then once I have confirmed that or rather, once I'm fairly assured that I'm dealing with a Parkinson feature or Parkinson disease, then I would like to go ahead with the first line of Parkinson's medications, that is a dopaminergic agents. For the motor treatment, I would like to add, depending upon the response, anticholinergic. But other medications which are not now commonly used are the COMT inhibitors, apomorphine, and amantadine. However, mainly I would be treating the patient with the dopaminergic and the anticholinergics. Is there any other surgical modalities? Yes, for the selective cases, surgical treatment or deep brain stimulation is also available. So in broad way, you have already opened the gates, that you know what are a dopaminergic, you have anticholinergic, and then you also mentioned about less utilized other three things, and you also know about the surgical cases. So that will stamp you. So if you are in the last 1 minute or 30 seconds, at least you have grasped everything. Don't just mention one thing and stop. Oh, I will give you treat with levodopa. Don't say that. So dopaminergic like levodopa, carbidopa, anticholinergic for the motor. There are other COMT inhibitors, apomorphine, amantadine, but they are less used, and surgical treatment for the selected cases. Done. If you have more time left, then they may ask about what dopaminergic drugs. The first line is levodopa, carbidopa. It is the most effective for motor symptoms. It is used with peripheral dopa decarboxylase. So why levodopa and carbidopa? Because carbidopa is a decarboxylase inhibitor, prevents the metabolism of levodopa, because levodopa is extremely short half-life, and hence to prolong half-life, we use carbidopa. What are the side effects? Nausea, vomiting, postural hypotension, motor functions, and confusion. So you have dopamine agonists. Then you have bromocriptine, pergolide, lesoride, have a weak anti-Parkinson's effect, but they may sometimes be used. So this is just for your knowledge. You may or may not mention. Pramipexole and ropinirole are a non-ergolide agonist and are not associated with cardiac wall fibrosis, which are associated with the ergolide agonist. Now, where do you get this patient? So, for example, the patient is scheduled for a surgery, and this patient is a nil per oral. What are your options available? Then you can say that we have got a transdermal patch like rotigotine to overcome the effect of to continue support her Parkinson's features. Selagelin, resegelin are the MAO-B inhibitors which are not used, and this is just for your information. So these are the advantages and disadvantages. So pure levodopa is the most effective for the motor symptoms, low risk of cognitive side effects. So, but it has a very short half-life. So you have this on and off phenomena, and hence carbidopa gets added to that. Though dopamine agonist had a longer life, and MAO-B inhibitors also are, but they are not routinely used. Case by case basis by the specialist, they are used. Now, anticholinergic, especially this benzatropine or benzexol, they are used when the tremors are really bad and they're very concerning. So they help to reduce the tremor, but it has a very bad side effect of dry eye, dry mouth, and it's very irritating. COMT inhibitors, they were at one point of time very much favored. They reduce the off time and increase the on time by reducing the wearing of effect. But they had their issues, and they are not as commonly used as our first line. Other are apomorphine and amantadine. Again, apomorphine given subcutaneously, so those who cannot take orally. And amantadine is actually an antiviral drug against NMDA receptors, but it's used in a mild anti-Parkinson's effect. Not commonly used. I have never used it. One of the very important questions which you might be asked is, what are the drugs that needs to be instructed or avoided in Parkinson's? So most of things you should be knowing, especially the common drugs. The very famous are the Ciranase or the haloperidol. Then remember, when you are prescribing any routine cough and cold medications, they might be having chlorpromazine or chlorprorazine. So be careful when you're using those. Atypical antipsychotics, risperidone, olanzapine, ziprasidone, they are the one. The safer alternatives are quetiapine, clozapine, are the one which I usually use for that. When you write antiemetic, Maxolon, to any person, be careful when you're writing, because Maxolon or metoclopramide will worsen it. Again, routine cough and cold, prochlorperazine, promethazine, you should avoid. Alternative, you can use a domperidone or ondansetron. Then MAO inhibitor, antidepressant, tricyclic antidepressant. There is some herbal supplements you should not be using. Methyl dopa, aldomet, is the one you should not when it comes to blood pressure. For the narcotic pain, meperidine and tramadol. Be careful. Muscle relaxants, especially nowadays, this one is not used, cyclobenzaprine. So not to worry, or unless you are an anesthetist from the previous generation, be careful. And certain cold allergen medication like pseudoephedrine, dextromethorphan, phenylephrine. So dextromethorphan is, again, it comes as a syrup, chesty cough, dry cough. So be careful when you're using that. Last one would be, when would you ask for the surgery? So the potential, one of in previous era, there used to be some radical surgeries of chopping off few parts of the brain, but now nobody does that. Very rarely I have seen anybody doing that. However, deep brain stimulation is very, 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 very promising, and it gives a fantastic effect, especially when the motor symptoms and the tremors are very bad. So it cannot be applied to everyone. So there are potential candidates. So the thing is, there should be a firm diagnosis of Parkinson's, have responded well to levodopa, carbidopa. They are alert. However, they are disabled because they are too stiff and they have a motor symptoms or tremors. So as you know, DBS doesn't involve any removal or chopping of the brain causing permanent lesion. So this process involves putting up a lead at a specific area such as thalamus, globus pallidus, or subthalamic nuclei, and then it is connected to a pulse generator, which is similar to pacemaker. Now this delivers a high frequency electrical discharge, and the effect is very, very dramatic and fantastic. So we can reduce the side effects of the drugs with DBS. And another thing about a DBS scan, it can be used at the bilateral regions, which would otherwise a radical surgery cannot be done. So DBS has its own indication, and it has a very good outcome, especially when the motor symptoms are extremely high. So that's how that covers your total MRCP examination, station 3 for neurology and Parkinson's. Any questions? No? Can we end the session here?
Aspirants, if you have any question, you can ask.
All right, then thank you very much. And thanks for coming. Hope this was useful.
Thank you, sir.